All right, everybody, we're going to go ahead and get started. We got 2 chapters tonight, so we want to try to knock those out so it's not too late when we get done. So again, chapter 12 and chapter 13, this obviously chapter 12 being behavioral emergencies and chapter 13 being environmental emergencies. So kind of some more specific stuff in behavioral and then an environmental. Again, like I said, it's our environment around us kind of, really could affect how we treat our patients and how our patients respond and all that. So interesting stuff there. So again, there's not always it's not always medicine and bandages and bleeding and all that sort of stuff in EMS. Sometimes it's literally just being someone, being a good listener, actively listening to someone, being there for somebody and being able to give them some type of emotional support. So some of the things that we see, though, from a psychological support standpoint, vary greatly. I mean, there's a lot of different things. People are, maybe depressed because of their finances. You could have somebody with some actual true psychiatric problems that are, either diagnosed or undiagnosed. And, substance abuse, kind of like we talked about on Tuesday, that could be, lingering effects from things of that nature. And so we need to kind of be real careful about dealing with these things. And main thing is kind of being calm and try to keep our patients calm and being understanding, not judging them and, calling them crazy and all these different types of, slang things that we might throw out there, all the time for people. But legitimately, we want to make sure that we try to keep them calm and try to understand what's going on with them. So again, in the psychological realm, we want in behavioral, patient type realm, we want to make sure that we are, getting a good history. So we're trying to understand, is this something that they've experienced often? Sometimes you may be able to get it out of the patient, and sometimes it may just be too sensitive. You may just, set them off. So we may have to try to get some information from somebody else. And a lot of times when we are dealing with some of this, somebody like this, generally it's either causing a problem for somebody, and so they call, or somebody's scared of that person, or very rarely do we get that person going, hey, I have some type of, behavioral emergency, psychological issue, something like that, and I think I need to go get help. Usually it's somebody else that's calling for them. So scene size up, being especially careful to make sure that the scene is safe. A lot of times when we have things of this nature, dispatch will usually send law enforcement also, just in case. And again, it could come out as something different. And so you may be there by yourself initially, but if you have any concerns about it, definitely call law enforcement. But it's one of those things where we want to make sure that there's no knives or scissors nearby, or guns, or, any other type of, weaponized type objects, around, just in case they get spooked or skittish or something like that, and want to think they need to protect themselves. So, like I said, like we mentioned before, if they're oriented and they're responsive to you, they'll respond to your questions. We can try to go through that sample history, try to find out some information from them, and try to work our way down that checklist. But if not, it's going to be kind of tough, and we may just get a little bit here and there. And so this is where that patience part comes into play. We need to be understanding and take it slow, and understand that they may not be willing to give you all the information you want. So the secondary assessment should rule out any obvious injuries and focus on signs of the medical illness. So kind of depending on what's going on, we want to make sure that they didn't fall down. They, because of their, psychological condition or something of that nature, that they didn't, jump out of a window, or, jump through a plate glass window or something, right? So, and have, any other type of injuries or anything like that. Of course, getting vital signs. Again, like I said before, this doesn't necessarily have to be something bad. It could be, something where their blood sugar got too low and now they're acting all weird, and it looks like a behavioral emergency, but it might turn into a hypoglycemia type incident. Okay, so again, same, just like we mentioned before in our patient assessment stuff, we don't want to jump to conclusions. Okay, go through the steps, ask the questions in order, and take your and do get good vital signs, and treat the patient. Okay, treat the patient. Don't treat we want to look at those vital signs and see what the actual patient's vital signs are and what the patient's body is doing. Okay, so we don't want to just try to jump to conclusions and try to think, oh well, he's acting like this, he must be bipolar, or he must be this, or he must be that. You might be right, but you may not. And if you're not, and you start throwing that stuff out there, especially to the higher level of care, you're going to get embarrassed real fast, or you're going to take a treatment route that may be inappropriate for the patient at that time. So, like I said, go through the process as it's laid out for you, and usually you're gonna end up on top, more times than not. So. Again, stable patients every 15 minutes, we want to reassess them, and unstable patients every 5 minutes. So reassessment needs to be, every few minutes. Every 5 minutes for unstable, 15 minutes for stable patients, just to make sure nothing's changed. Again, if it were to be some other type of issue causing it, that maybe if it might be getting better or worse, and that way we can maybe make a better treatment or transport decision. So behavioral emergencies are situations in which persons exhibit abnormal, unacceptable behavior that cannot be tolerated by the patients themselves or by family, friends, and or community. So that's kind of what we were mentioning earlier. It's usually somebody else that has the problem. They may be living at home with parents, maybe an adult that lives at home with their parents because they have these issues and can't function well in society. And so something happens where they start to get violent or agitated. They try to they went to the store and they try to jump out of the vehicle. In any number of different reasons, but for some reason the family, friends, the community, people around them are concerned to some degree, whether it's about, like I said, whether it's scared for their well-being or for the patient's well-being. One reason or the other, they're the ones usually that are going to be calling. So, uncontrollable diabetes, respiratory conditions, strokes. Like I said, there's several different reasons why. It could have been somebody that had been in a vehicle accident and they have a brain injury, and or was in a sporting accident and had a brain injury, and so they may be 25 years old and everything else is fine with them, but they have the temperament of like a 10-year-old. Okay. And so they lash out, they yell out, they scream, they get agitated very easily, things like that. And so the family and friends are, it's concerning for them. So, but again, other medical conditions like high fevers, infections, that sort of thing, could be cause for concern. So it's just one of those things we have to be, cognizant of, and that's what I was telling you, is like we want to make sure that there's not, we're not, judging them unnecessarily because we never know what the actual reason behind it is. Some other psychiatric illnesses: depression, panic, psychotic behavior. Some of those things can be caused by alcohol, chemical substances, drugs, things like that. And it's it's just one of those things where they have a lot of different um, signs and symptoms that are very similar. So, like we mentioned on all these medical issues, we're not there to diagnose. We may try to get close. We're going to try to get down to the root of the issue, but we don't diagnose them with depression. We don't diagnose them with anything. And so we want to make sure that we are just getting down to this, as much information as we can, trying to get down to the root of the issue at hand, and try and see how best we can help them at that moment. Situational stresses: death of a loved one, serious injury to a loved one. You might see that, excuse me, in a lot of different areas, situations where someone's died immediately, like in their presence, and especially or unknowingly, and you have to deal with that on scene. So you have serious accidents or suicides, things like that, where it's untimely death for someone, and you have people around them that are just just lose it, and they will be unconsolable, sometimes completely upset, angry, just depending on what the issues are between them. And so you never can tell what they're capable of, so you have to be really careful about that, what you say around them and all that. So it is a very touchy situation to be in. Bear with me tonight, folks. I think our internet's running a little slow. Everybody see what is a situational crisis?
Yeah.
There we go. Okay. So state of emotional upset or turmoil, caused by a sudden and disruptive event. And, that could be, some type of like active shooter, or, like I said, some type of, car accident with serious injury, or, some type of, seriously unforeseen event that happens in a person's life. And, they don't know how to handle it. It's their coping mechanisms are not there. They're not built up for that. And, usually it's a short term kind of thing. It's just, they have to calm down. They have to have somebody that can calm them down, that they feel safe with. And it's, like I said, it's usually, has the potential to cause, basically socially unacceptable, destructive type behavior, dangerous behavior. And so, like I said, somebody's just so distraught that they're running out in traffic, right? They see somebody's dead body and they just lose it, and they have just complete meltdown, and will try to grab a police officer's gun, or literally just run, see somebody commit suicide and run right into the other room, grab a gun and shoot themselves. You know what I mean? Like any number of incredibly, uh, just out there type actions that most normal people wouldn't do. So like I said, under that increased stress because of that crisis, they just lose their ability to process. So for emotional phases, people may not experience every phase or anything like that. And like I said, you see that in some of these big incidences like terrorist attacks and active shooter events and bombings and things of that nature. And everybody processes things differently, right? So if you've been a firefighter for 10 years, or police officer, EMT, or something like that, or whatever, for a long time, and you've seen a lot of bad things, you're going to process something differently than somebody who works at the bank, or, is a teacher at the school or something, so you just may, and have never been through those types of, critical incidents like that. So high anxiety or emotional shock is one of those. Flushed red face, rapid breathing, rapid speech, increased activity, loud or screaming voice, general agitation. Again, that's one of those that you see in a lot of people who are just have had something bad happen to them in their life or whatever. They find out that somebody has passed away, or that maybe their spouse has left them for their best friend or something, and usually they get to throwing stuff and screaming and yelling, and they're crying, all these different types of, you can't console them. You can't say, oh, come here, let me hug you, right? No, don't touch me, get away from me, right? So they're agitated. And so that's kind of what that's referring to. Cool, clammy skin, rapid weak pulse, vomiting and nausea, general inactivity and weakness. Sometimes you see that where people get so distraught that they'll throw up, that they will sometimes lose control of their bowels. They'll pee on themselves, they'll urinate, defecate on themselves. And so, some people just, especially people who are not type A in nature, and literally just have no stress inoculation. They haven't been in these type of situations at all. They're maybe lived a very sheltered life, or maybe they're from a different culture, and they visit someplace, and something bad happens, or something bad happens in their life that they were not prepared for at all as a child, and then it happens all of a sudden, and their brain does not know what to do with that information. So denial being one of these actions, refusal essentially to accept the fact that an event has occurred. No, he's not dead. That's not really him. I know, I've seen him. He left for work this morning. That's not him. I know it's not him. It's going to be okay. It's not him. Right. It's easier to just say, no, that's not what's happening, and try to get rid of that information in their head. As it say in here, do not argue with the patient. Try to understand the emotional and psychological trauma. It's best just to kind of be there in their presence, but give them some little space, and let them try to process it. And like I said, we're not going to kind of we're trying not to buy into that, especially if we know for certain that whatever has happened to someone, or that something bad has happened in an area, so my mom was in the World Trade Center, and I just seen there's a plane hit the World Trade Center, right? Yes, there was not, no, that wasn't the World Trade Center. That was the Empire State Building. That's not where my mom works. My mom works at the World Trade Center, and just kind of, but you may just have to go, no, ma'am, that was the World Trade Center, but we don't know anything yet. There's no facts yet. We don't know who's been injured or anything like that. So let's just, let's get some facts before we, start getting all worked up, and, just trying to reassure them that we don't, if we don't know anything, we don't know anything. And, it's just kind of just general reassurance and reasoning that everything's going to be okay, and that we'll work through it regardless of what the problem is, and, things like that. So denial, anger is, one that pretty jumps out there pretty quick. Just mostly kind of emulates in frustration. You get some people that are, will go and punch the window out of a vehicle just because they're so mad, punch a hole in a wall, kick a wall, throw stuff across the room, and so it's a normal human reaction. It's just one of those things that it's one of those ways that people respond. Some people will not say a word, will not cry, will not scream. They will go sit in the corner and not say anything. And there are some that just immediately will become frustrated, angry, upset, emotionally distraught. So everybody, like I said before, everybody handles stress differently. And, that you may just be the focus of that. You may be the target of that. And it's one of those, again, it's not personal. Generally, they don't know you. And it's one of those where we'll have to just absorb that, okay, and just understand that they are in this heightened emotional state, and that they are not trying to do that on purpose to you. So just accept it, take it and let it go right back out. And again, try to be reassuring and calming, and don't get upset back at them. And what'd you call me? What'd you tell me? No, we're not doing all that, right? We're not going to try to make it worse. Because again, they'll start to focus on you, and then they're in this angry state, and it's just going to build. Okay. So remorse or grief, the this this action is generally one that it may not, like I said, these may not fall right in order. So, like I said before, it may not be all of them, or it may not be in order. But generally, this is one that you'll see the most of. And it's the acceptance of the situation. Once it kind of hits them and they go, you know what, this is real. This person died, or this person is seriously injured, or this has happened to me. And, I'm gonna lose my leg, or something bad is going on with me, and I know it. And they may just realize that they're schizophrenic. So they're in the normal phase of schizophrenia, where they're in a normal state, and they're talking to you and be able to tell you, like, I know there's something wrong with me, I'm really sorry. And then like 2 minutes later, they're a completely different person. And so they may, in that normal state, they may be very upset and grief stricken, because they realize that they're like Dr. Jekyll, Mr. Hyde. And so so it could be very sporadic with their behavior and how they act. So crisis management, crisis, again, like we've been talking about, is kind of that, what's a crisis for you may not be a crisis for somebody else, and vice versa. And it's one of those things where we just kind of have to take it as it comes, and try to deal with it professionally. And it's it's important, like we talked about before, to get a good medical history, get a good scene size up, and if the situation will allow, to get those vital signs, and being able to communicate effectively with that patient is key, right? So, and again, that may be all that you get to do, is just talk to them. Maybe they won't let you touch them, they won't let you do anything to them. So it may just be, hey, I just need to, try to count some breaths while they're talking, or, see if they'll shake my hand. Maybe I can kind of feel their skin condition, stuff like that. Little things that you can just try to get from them. Hey, are you hurting anywhere? Do you feel bad? Do you feel sick, or anything like that? Just generalized questions that are not really digging too deep, but that'll give you a little bit of indication whether or not they're having some other type of medical problem. Because again, these patients may be having some other type of medical condition, so that's a good point, is that they are, you may have a legitimate other medical problem, a physical medical problem, that is happening at the same time that they're in these states. Okay. So we have to kind of tiptoe around the state that they're in to try to get to helping them with their breathing problem, or their cardiac issue, or blood sugar, or something like that. So communicating with the patient, like we've talked about before, introduce yourself, ask the patient his or her name, call them by their name. Hey Jim, I'm Justin. What's going on with you today, man? And again, like we mentioned in patient assessment, it's a conversation. Okay, it's bedside manner. Treat them like a normal person, like you would any of your friends or family. We're going to be a little bit more, courteous and direct with our questions, but they're not. We're going to treat them, as civilly as we would anybody else, right? So what can I do to help? What's going on with you today? What's hurting you? Any of these little things that we can try to help to see how we can go forward. Okay. Again, don't lie to them. Be honest, warm, caring, empathetic, and head shakes. Yeah. I agree with you. I understand what you're saying. I feel your pain. That sort of thing. And sometimes they'll tell you, oh, you don't know what I'm going through. You don't know this. You don't know that. And if you've been through something like that personally, or somebody who has personally, how that is, then that's a great opportunity to connect with them. But don't lie to them and go, oh yeah, man, yeah, I lost my best friend in a motorcycle accident, and make up some crazy story just so you can relate to them or whatever. Don't do that, because at some point they can call you on that lie, they can call you on that bluff, and it's probably not going to end well. All right, you're going to lose all that trust that you just tried to build. Position yourself at the patient's eye level. This is a pretty good one, especially for behavioral type emergencies. You don't want to be in a compromising position, but as you can see on that top picture where the guy is kind of squatting down, this guy's sitting down on his butt. He's got one leg underneath the other leg. He's probably not just going to pop up real fast and push this EMT over, right? So, but this guy could stand up whenever he wants to. He's not on both knees or anything like that. However, this guy on the bottom picture, he's kind of towering over this woman, so it's a little bit intimidating. So if you're physically able to, try to, take a knee, or, give yourself a few feet of distance away from them so they don't feel threatened, but get down there where, at their level and try to talk to them. Kids especially. So establish eye contact, use a calm, steady voice, be reassuring. Try not to, like I said before, trying to let those negative feelings or comments that they make, affect you. It's not a personal thing. Again, like I said, majority of the time they don't know you and they're not trying to attack you personally, even though they may say personal things towards you. Generally it's probably going to be because, most normal people don't do that. So generally it's probably going to be because of whatever their issue is. Restatement, rephrasing a person's own words and thoughts and repeating back to them. That's just one way to make sure that you understand what they're saying. If they're kind of rambling on, or if they have some strung together, phrases or something like that. It's best to try to pick out the things that are important in their phrase and repeat it back to them and see if they catch it and go, oh, no. My head hurts and I just kind of feel like I'm gonna throw up, and so that may be what they meant to say, but what came out was something not nowhere near that. So redirection helps focus the patient's attention on the immediate situation or crisis. And we usually get into this a lot. We mentioned this with elderly patients before about, them kind of just rambling on about all these different types of issues that they've had over the last 10 years, or, all this problems that they've had at this doctor, and, their son, never comes and sees them, and all this other stuff. And so, if we can kind of redirect them back towards, okay, well, I hate to hear that, but, tell me what's going on today so we can help you. How can we help you today? And, just kind of get them back on track. And sometimes that may be where we need to kind of get them in a spot where they feel a little bit more comfortable, or that they are not around a bunch of people, and we can kind of focus on what the issue is instead of having people jump in, and family members want to jump in and tell you everything. And so again, be empathetic. We want to try to be there if they want to just share their feelings or tell their story about what's going on with them, and that's all that really is going on. That's what's causing this, depression or panic attack or whatever it might be. Fine. We'll sit there and we'll listen to whatever it is for a reasonable amount of time. And then, at some point we kind of have to maybe share your thoughts, just your general thoughts. I wouldn't go too personal, but, you want to try to stay on the more positive end of things and give them some hope, and that way we can try to leave them in a little bit better place than what we found them. Because the majority of the time, these types of patients, they're not going to get in the ambulance. They're walking, talking, breathing. They're probably not in a lot of pain or anything like that. They're not in a lot of physical pain. So generally, they're just going to be those that you talk to for a little while, and then they calm down after 10, 15 minutes, and they're like, yeah, I don't want to go to the hospital. I'll be fine. I'll be here. Or, hey, my friend's coming over, or my family's here, and I'm going to be okay. So assessing the patient's mental status, we mentioned that with AVPU and a couple other ones. There are, that's a good one, especially if they're right off the bat, they're not able to focus on your questions, answer your questions appropriately, and we're probably going to have an issue with their mental status, their legal capability to make decisions on their own, right? Like we talked about early on. So it's important to make that mental note of their mental status and ensure that we understand where they are in that spectrum, and that way we know how we can move forward. Mentioned this a moment ago about crowd control. Sometimes people are just anxious with a bunch of people right in a little small room, and stuff like that. Or they're sitting in the car and there's 4 people at each door. Don't be afraid to just turn around and go, hey, everybody, I need you guys to go outside for a minute. Everybody go outside, husband, wife, mom, dad, whatever. If you guys just hang out in the living room and let me and my partner talk to Mr. Smith for just a minute, and we'll come get you in just a second, okay? And that way we can try to, alleviate some of that stress. Domestic violence, we see this quite often, almost, at least several times a week in this area especially. So, it could be anything from elder abuse, child abuse, spousal, domestic partner type abuse. But it's, again, one of those things where if it's reported as any type of violence, violent action, whether it's husband and wife or brother and sister or whatever, or just 2 friends fighting or anything, generally the law enforcement is going to be contacted as well, and they'll make sure the scene is safe, and then they'll tell you it's safe for you to come in and start doing whatever it is you need to do. But if not, if you're there for some other reason and it turns into something domestic like that, then you need to make sure that you contact dispatch and get some help on the way. Because domestic calls, for those of you who don't know, I know there's a couple in here that do, but domestic violence calls historically are one of the most dangerous calls that we have in law enforcement. You may not think that, but over the years, that's it's been one of the major sources of injuries and things like that towards law enforcement officers, because generally they will fight, but they will also protect each other. So when one is realized that the other one's going to go to jail, they'll be remorseful, or the other one will have intimidated them so bad that they know that there's going to be retribution because of that, and they will attack you. So if you're there as an EMR and you start doing a physical exam or something, you go, oh, you got a bruise here, you got a scratch there, you got a bump there, and you start doing that, they may get upset and go, no, I don't, that's old, don't touch me anymore, don't look at me, don't get out of my house, I don't want you in here, and so they could turn on you even though they're the victim, and so it's a very common occurrence, and it's one of those that you really have to be concerned about and make sure, like I said, that you have help there just in case. The other part of that, like with child and elderly abuse especially, is if you're doing a physical exam or if you notice things that look to be abusive abusive signs like broken bones, cuts, um, bruises, burns, scars, things like that, different stages of healing. So like it's one that's like red, one that's black and blue, stuff like that. Internal injuries that you might be noticing, or that they may be telling you about. These are potential signs of domestic abuse. And again, when we say domestic, it's not always just adult male and female. So again, like we mentioned, especially in children and elderly, we really want to look for these signs and make sure that we are reporting them to law enforcement in an official manner, not just a whisper on the way back to the ambulance, or step outside and go, man, I don't know, they kind of look like she might have been beat up, for a while now. Now we need to do a little bit more official than that. We want to make sure we put it in our report that we, that we advise somebody at, make sure that it gets reported on camera or something like that. And that way, you're covering your butt, and then you're giving the law enforcement agency an opportunity to investigate it. So emotional symptoms, again, depression, suicide attempts, abuse of alcohol or drugs, feelings of anxiety, distress, and hopelessness. These are some of the things that you may encounter, and especially this is definitely something you want to try to separate that victim from, if the aggressor is there still, or other people. They may not want to tell other people, have other people know. So it's best to try to get them alone and see if they'll give you, hey, listen, I'm just here to help you. I'm not law enforcement. I just want to know, do you have any other injuries? What's going on? And see what they'll tell you. But sometimes they're very adamant about protecting that other person. So like we've been talking about, we want to make sure that your safety is paramount, and make sure that you are staying safe in that situation. Like I said before, separate the patient from the abuser. Try to keep from judging the patient. The presence of law enforcement personnel, it may be helpful. If they are there, like I said before, they're generally going to be there first anyway. But it may be one of those situations where, a female victim may feel comfortable talking to just the female, EMR or EMT or paramedic, and we need to ask the law enforcement officer, hey man, ma'am or sir, you mind stepping out of the room for just a minute? Let me talk to her, alone. And, I think she wants to talk about something, and generally they're going to understand, and they'll be close by, but they'll give you some space to do your thing. But when you do that, like I said, just be cognizant of what's around them, and what their stress level is, and what their, attitude is towards you in this situation. So there are some state reporting requirements, and more so whenever you are working for an agency, and you need to make sure that you know what those are. They're different for every state. So cycles of abuse, tension phase, the abuser becomes angry and often blames the victim. The explosive phase, the abuser becomes enraged and loses control, as well as the ability to think clearly. And then the makeup phase, the abuser makes promises which are seldom kept. It's, these phases are not all inclusive. They don't always happen in that manner, but things to be looking for, especially if you go to a location multiple times, and maybe in a short period of time, or over the course of a few weeks or a couple months or something, and you're getting multiple calls. Maybe whenever he leaves to go to work, she calls and says, hey, my arm hurts, or my chest hurts, or whatever, and you do a physical exam and she's got bruising on her ribs and all this other stuff. And when you ask her what happened, she says that she fell or whatever. So you start seeing a pattern where she only calls when he's not home. So little things like that. You might want to start bringing the attention of somebody and seeing if we can start to dig a little bit deeper. Again, loud, obscene, or bizarre speech, pacing, inability to sit still. Especially if the aggressor is around, you may see them act differently. So, look for those types of things. They may not. They either want to stand way far away from them, or they have been preconditioned to be right there, to not say anything. To be very, to not be very forthcoming about it with information. You can look for signs of being coached. Whenever you ask them questions, they look at them first before they will answer your question, to get some type of acceptance, for them to be able to say something. So it's it is a little bit of a chess game, and unfortunately, in EMS we kind of have to play that as well. Law enforcement is probably at the same time doing the same thing. So you may have to compare notes kind of after you leave, and see if if they got the same kind of vibe that you did. As it may be very evident, they may be very forthcoming. Yes, he beat me up. He beats me up all the time. He beats my kids. All this other stuff, and it's not our place to confront that aggressor. At that time, it's just not. We're not going to sit there and go, "Why'd you do this to her? Who do you think you are?" All this other stuff. You can be upset. You can be it's obviously you're a human being, and so it's going to be potentially upsetting for you to know that, to hear that, and them to be right there. A lot of times you just need to do what's best for the patient, and if they want to go with you, they'll go with you. If not, provide whatever care they'll allow you to do, and then and then you go ahead and leave the scene, whether it's with the patient or without, and then you can vent to your partner, vent to law enforcement, that sort of thing, and try to work through that. But it is it's never easy to deal with that. Try to have one person talk with the patient. We don't want to, like I said before, we kind of want to have a rapport with the patient and have them trust us and feel comfortable talking to us. And sometimes it's kind of difficult when we have 2, 3, 4 people trying to talk to them. Oh, I know, I can tell you about this, and somebody else, oh, I can tell you about that, and everybody's an expert, So generally, it's going to be the person that is going to be taking care of them longer term. So a lot of times it ends up in the paramedic's lap. And like I said before, if you have a female partner and it's a female that you're dealing with, you may ask them, hey, would you feel more comfortable talking to my partner about this, and maybe a sexual assault thing or something like that, especially, young girls and even young boys. And so they may just feel comfortable talking with somebody of the same sex about those types of things. Violence against EMRs or EMS in general is pretty common. I mean, it happens just because, like it says, we work in small numbers, late at night, early mornings, high crime areas. We're in the back of a small ambulance. There's a community setting where there's a lot of people around, and we have to deal with a large group of people in the area. Crime scenes, gangs, shooting scenes, any number of different types of things, domestic disputes, like we just mentioned. So it's definitely something where we take that scene safety, which is right at the top of the list, right? Every time, scene safety, body substance isolation, or PPE, we want to make sure that we are, looking at those scene safety issues and taking care of those first before we start focusing on our patient. The armed patient, it's not your role to handle an armed patient unless you're a law enforcement officer. You know, that's why I like to go and back you guys up a lot of times, because I'm I wear multiple hats, right? So I'm rolling in there with all the capabilities of a law enforcement officer, but also with all the capabilities of an EMT and a tactical medic and stuff like that. So I try to come in there and at least stabilize the situation from a law enforcement perspective, start that scene size up from the EMS perspective, start a little bit of patient, either patient care or patient, history stuff while you guys are en route into the scene, and then I can turn it right over to you with a little bit of a start there. And so that's kind of the way it should be for any case. We want to try to set that patient up in a good position to where you have a lot better, it's much easier for you to start, treatment and your patient assessment. But be alert. Someone assistance. If you know right from the jump that something's not right, don't get out of the vehicle. Don't get out of the fire truck. Don't get out of the ambulance. Don't get out of your POV, and back out of there. Call dispatch. Let them know, hey, we need some law enforcement here. This is there's 50 people around the patient, and they're all angry, and they have bats and pipes and guns, and just leave the area. Go a few blocks down, hang out for a second, and wait for them to tell you it's okay to come in. All right, it's just not worth it. You can't do anything for that patient if you're a victim. Okay. So again, it's an emotional disturbed patient agrees to be treated. Few legal issues should arise. Like I said, we want to make sure that we understand what their level of consciousness is, what their level of understanding. So, we want to make sure that they are, we want to make sure that they are understanding of person, place, and time. Right? They know who they are, where they are. What kind of what the date is, and all that sort of thing, and trying to get an idea of make sure that they can reasonably understand what you're asking them. If they're disturbed and they refuse, you may have to provide care against the patient's will, in that case where they're not able to do that. So sometimes it's, it almost looks like it's inappropriate. And that's usually where we have to get law enforcement to kind of step in and go, hey, get on the stretcher right now. Generally they'll understand that if the paramedic or somebody especially is saying, hey, this person's not in their right mind, they can't answer, legal questions legally, but they have got to be treated, or something bad's going to happen to them, then generally they're going to go with your advice, and as long as it's under a good auspice like that, but you just may need their authority to you may just need them to assert their authority on the patient so that they understand that, hey, this is legally, we have to do this against your will. So if you're required to restrain a patient, consider the following factors: the patient's size and apparent strength, the patient's gender, type of abnormal behavior, patient's mental state, and the method of restraint. Generally, you are not going to be one that actually restrains a patient for transport per se. You may have to help restrain them on scene, but generally you're not going to make the consideration to physically restrain them over course or a period of time. It's typically going to be the paramedic, because they're going to have to get medical control authority to do that. Quick story: I had an elderly female patient that was normally 180 degree different than what she was this day. Nice lady, and lived by herself. Kind of a rundown house. Lived by herself. She had like 8 million old drink cans, soda cans in her back porch. Just a bunch of cats, and just kind of a deplorable type situation. and people went and kind of took care of her. Went by one day, and she was just cursing them, yelling and screaming at them, just horrible things she was telling them that she would do to them, and all this other stuff. Just, I mean, completely out of character. Something was going on mentally or chemically in her brain that was just way different. And so I got there as a law enforcement officer, got there and started trying to figure out what's going on. They called us, called the ambulance. The ambulance had to wait for a minute until we figured out what's going on. Me and my partner go in there, and she's got a knife. She's got a knife. She's threatened to kill us. I mean, she has a look in her eyes that she would do it. And, just the look on her face and the things that she was saying, I will kill you. I'll kill your whole family. I mean, she was absolutely very serious. And, she had the knife. She was, making aggressive, movements here and there. And, we were, a good, 12 feet away from her. And my partner was the same way. He's trying to, de-escalate the thing. Ma'am, please, it's, it was as nice as we possibly could, even though all the crazy things that she was saying and hateful things that she was saying towards us, we realized that that was not her. That was not her saying that. There was something going on in her head. So or in her brain. So, we tried. And then she turned to me and just focused right in on me and was like, I'm going to kill you. I'm going to take this knife and I'm going to stab you with it, whatever. And I just told her, I said, no, ma'am, no, that's, it's not a good idea. Let's not talk like that. It's not good to talk like that. And she just started running at me. She ran right across the room with a knife in an overhand stabbing motion and a hacking type motion. And I had to tase her, so, as soon as I tased her, we got her kind of in custody and took her outside and, still just hateful, spitting, biting, kicking, all sorts of stuff. And paramedic comes, same thing. So they get the authority to restrain her. And it takes, this is a little bitty 90 to 100 pound little old lady. And it took 5-6 people to get her onto the stretcher and then get the correct restraint for her. She was coming out of the restraint. She was, tearing stuff. She was, about to fall off, twisting herself into a pretzel. So, we had to use sheets. We had to use, rolled gauze and things like that to make soft restraints. And they have a lot of different types of restraint things. There's all sorts of different ways to restrain patients, but generally it's going to be, we're restraining them so that they don't hurt themselves, and of course so they don't get away. But generally, when they're that bad off, they may also, depending on the service, they may get medical control for a sedation. So essentially just a general pharmacological restraint. So essentially just knocks them out, or makes them calm way down. And that's pretty rare, but it's a potential that's out there. So attempted suicide, you may use reasonable force to defend yourself against an attack. Again, if somebody, like we mentioned, I think the other night, where if they want to, they're dead set on committing suicide and they don't want you to stop them, they may, they may try to take you out first, so you can't stop them. So that's one of those reasons why law enforcement is usually there first. And we make sure they don't have any weapons in their possession or, close to them and things like that, so that we, whenever we come in, it is one of those things where you kind of feel a little bit safe. You can kind of focus on the patient. You're not so worried about them hurting you or hurting themselves. So, we try to get down to the root of why would you want to do this, man? Why, have you been thinking about it for a while, and And a lot of times, whenever they make, and especially in this area, whenever they make suicidal threats like that, and it's confirmed, we can generally confirm it either through them or through somebody that was affected by it, pretty closely. Then the paramedics have the authority to call medical control, and usually medical control will, and they give them all this information, and generally medical control will make them go to the hospital. Like it'll be against their will. So they have that authority to do that. Like I said, it happens every now and then, but that's we get a lot of these calls for people who say that they're going to kill themselves or something like that and commit suicide, and we like I said, we get there and we're going to have to kind of try to get down to the root of the issue and talk to them and stuff like that. And we kind of have to tiptoe around that end result. Generally, if they're like, yeah, I did say that, or, the family member's like, well, Jimmy, tell them what you told me. Tell them what you told me about, putting the gun in your mouth and pulling the trigger. Mama, don't say that. I was just mad when I said that, whatever. Right. And so, well, there you go. There's an admission from them that they did say it, and they do have the means to carry it out. And so generally when they do that, the paramedic is usually going to make that determination, and generally they're going to go against their will to the hospital. The hospital will then kind of intake them for a short period of time and have them evaluated, and then generally they kind of get let go as long as they don't have any other underlying issue. If it was just some type of general emotional stress that caused them to say stuff like that, and they really didn't want to do it, they'll generally just be let go in a short amount of time. So again, support the patient's ABCs, whether it's by pills or weapons or a knife or whatever, however they think they want to do it. We want to make sure that their ABCs are supported. If they cause any open wounds, we're working our way down our patient assessment, taking care of any life threats. Treat the patient for any spinal injuries if they fell or tried to hang themselves or anything like that. They may have a potential for a spinal injury there. Again, we're not judging the patient. We're not going, man, why in the world would you want to do that? What is your deal? Why are you acting like this? Jeez, man, don't be stupid. Don't be crazy. Why are you crazy? We're definitely not going to talk like that. And don't talk like that while you're on the scene. Stepping outside, you're over there in between two fire trucks or fire truck and an ambulance, and you're telling your buddy, man, this dude inside is freaking nuts, right? You never know who's listening, okay? You can get in some serious trouble for just general remarks like that, even in a private conversation. You never know who's listening. So when there's family, especially when there's family around and friends and neighbors and all sort of sort of stuff, be very cautious about what you say about patients. Post-traumatic stress disorder. This is something that we could deal with. The patients can deal with. You don't have to be a 4-time combat veteran, having kicked in doors in Fallujah and killed a bunch of people and watched a bunch of roadside bombs kill all your friends to have post-traumatic stress disorder. Now, obviously, all those things that I just mentioned are potentials for that. And we've seen that in great numbers with our military, but just understand that everyday people, civilians, can have post-traumatic stress disorder as well. And we've learned a lot about that, unfortunately, because of the military. And so we've been able to, see how we can best treat people, how we can best deal with people that have these types of issues, these mental health issues, behavioral conditions. And, it's essentially, it can be, like it says here, a triggering type experience, or, you witness a terrifying event, and it may just be that, all of a sudden your heart starts racing. Your palms start getting sweaty whenever you smell something, hear something, see something, and that triggers that response and that brings you back to whatever that issue was. So sometimes they may just go, you know, I don't want to go into a dark place. I got to have a light on. You know, I can't go. I can't be around helicopters. You know, if there's a helicopter that's going to be coming landing at the hospital, I don't want to be near it. You know, or you know, if there's going to be if I'm going to have to fly on a helicopter, I'm not going. You know, so there's all sorts of different things like that that they don't want to smell men's cologne. Okay, they don't want to hear a car horn or something. I mean, any number of things that might trigger um, their uh, their regression back to that time. So big thing is like I said, we want to try to keep them from harming themselves. We've had plenty of veterans hotlines. We had one just the other day, veteran hotline that had the gentleman had called and made mention that he had a shotgun. He was going to hurt himself, and the veterans hotline called law enforcement, and then we went out there, and between us and the ambulance, we talked to the guy, and he really didn't want to, but he was just stressed out. It was a financial issue, and he was just so tired of dealing with it, and it was just not getting better, and been dealing with it for a long time, and so so that's one of those things where we just kind of have to work our way through it, try to stay positive and be supportive, and hopefully we can try to get them some help. I mean, there's a lot of resources now for post-traumatic stress at a lot of different levels, and especially for those of us that are in emergency services. It's a big deal. We go through a lot of stuff, we go through a lot of stress, and we see and deal with a lot of the worst things that people, that most of society doesn't see, right? And so, if you can imagine us getting PTSD, then imagine somebody who is not stress inoculated. They have not had those little doses of stress over the course of several years that kind of helps their mind understand it. So imagine if you don't have that, and your mind's not prepared for it, then it's essentially makes, and this is kind of a good way to explain it, is it's essentially like a mental wound. Okay, so they have a big open wound. They could have a small one or a big open wound in their mind, in their brain. Okay, and so we're there to help provide mental first aid. Okay, we're going to help stop the bleeding, which is some of that crazy, just off the wall, manic behavior that's, just like we talked about before, that's just not acceptable. It's angry, yelling, throwing stuff, breaking stuff, breaking car windows and all these other things. And, talking about shooting people or shooting themselves and all this other stuff. Right. So that's the bleeding part. That's the bleeding out, man. We're there to put the tourniquet on that, try to stop that from happening, calm that down, to where we can manage it. Right. And so once we do that, then we can help to we slowed the bleeding down, we stopped the bleeding, and now we can start to go in a little bit more of wound management, wound care. We're cleaning off the blood, we're looking at seeing what we got, we're putting a bandage on it, and now we're starting to do into a little bit more of supportive care. Right. So we're not worried about them, we're not worried about that big wound getting worse. Right. We kind of made that better. And now we're starting to, a little bit more slowly figure out, what we need to do over the next little bit of time to help that wound heal. Okay. And and I'll put it in that context for you because you really need to understand what your role is in that. It's big. And especially for us, if we're treating ourselves, or we're treating each other in public safety, especially, and in the military, that, we are at the forefront of that. All right. Just talking about things with each other, discussing bad calls, things like that, and working our way through, what could have been done, or what we could do, is key for that mental first aid. Okay. Uh, you know, especially when you get to a position like this where you are caring for other people, there's a lot of what if, there's a lot of why, what could I have done better? that person died and I was the primary one treating them. Did I do something wrong? Is it my fault? And so sometimes we take a lot of that blame on ourselves because we're in charge of caring for them. And so that's one of those things where you have to work through that with your peers, and usually peer support is what helps really slow that bleeding down and make things better. Where it's natural. Post-traumatic stress disorder, things like that, is what we're referred to as a natural reaction to an unnatural or event. Okay, so it's a normal reaction to an abnormal event. That's what I was trying to say. So you're not crazy. You're not you're not sick in the head. You're not weak. You're not inferior because you feel this way, because you have these symptoms. It's not. It's like I said, it is a normal reaction to these these incredible stressors that we get put under. So moving on to sexual assault, again, a very stressful, emotionally tumultuous time for people. Again, a lot of times when we hear this, we think of females. You've got to understand that males can be sexually assaulted as well. All right, by females and by other males. I was told when I got to Germany in like 2007, I sat in a briefing and they told us that actually the majority of sexual assaults at that military base and around that military base were male on male, and it wasn't necessarily homosexual in nature. It wasn't these people weren't necessarily homosexuals that were committing these types of acts or anything like that, or victims. So it's one of those things that you really have to be sensitive to and try to be understanding of. It may not be something that you deal with in your personal life very much, and it may not be something that you're exposed to. But again, it's something that affects a lot of people, and it takes a very gentle hand to deal with. So again, you may have to delay all but the most essential treatment until a responder of the same sex as the patient arrives. And we mentioned this earlier about, just in general, patients that may want to speak with somebody of the same sex, and just maybe make them more comfortable. The first priority, as it says, the medical well-being. So we want to make sure there's any life-threatening injuries or issues that we need to be concerned with. We want to take care of those right away. Remember, sexual assault is a crime. So when we're dealing with a patient of sexual assault, law enforcement, again, is going to be there, be heavily involved in that. And there is a process that needs to be adhered to. Okay. If you do not need to, if there's not, major bleeding coming from the genitals or something like that, that we need to try to control or assist with or something, then there's no reason for you as an EMR to take that person's clothes off or, expose anything or anything like that. It's just not. The paramedic may not. Okay. Again, if they report that there's no, serious injury there, there's not something that we need to be concerned with on the medical side. As far as a life-threatening issue or a direct need to control bleeding or to address a respiratory issue, leave it alone. Okay. Again, this is a criminal investigation, and we need all the things that are surrounding this. Okay. The sheets on the bed, or location around where they're at, so maybe, vehicle seats, the ground, if you find them on the ground, things like that, all these different, the area where the patient is found is a crime scene. Okay. If they've been moved from one place to another before you were called, that's understandable, but irregardless, there are fluids that may be, exposed to that area. And so we want to move the patient as little as possible. Don't remove their clothing, and, don't disturb the area around them whatsoever. Like I said, unless there's just, like I said, some serious medical need arises. Okay. Avoid aggressively questioning the patient. What were you doing? Where are you at? Why were you there? Who are you with? A lot of times that's not for you to know. It's not necessary for you to know. And we want to focus on our sample history, our medical issues. Do you have any pain? Where's your pain at? Check your pain scale. Generally, where's your pain at? We don't need to get into how long have you and your boyfriend been together, or why would you think he would do that? We don't need to ask any of those types of questions. Okay. Again, treat the patient with empathy, especially, younger patients. We want to try to be, again, very empathetic and understanding, make sure they understand that they're a victim, that it's not their fault. And that we're going to, we need to do things a certain way, so we can't let them take a shower. We can't let them, clean themselves, things like that. It's uncomfortable, maybe uncomfortable for them, but, we want to make sure that we kind of do our thing, make sure the patient is okay. And then generally they'll usually be transported by the ambulance, just so that they're in somebody's care and supervision, from point A to point B. And then once they get to the hospital, then there's a whole other gambit of processes that legally have to take place. And so there's even a certain nurse, there's a certain specified type of nurse that has to do, a sexual assault kit, what they call it, a kit, and where they're going to take samples from the patient and things like that. So not even just a regular nurse can do that, for it to be legally binding. So death and dying, never easy. Doesn't matter if it was expected, if it was a hospice patient that's been on their deathbed for 3 months and, or 5 months or 6 months or whatever, and everybody in their family knows it and everybody said their goodbyes, and, it still doesn't make it better. Unfortunately, we're going to encounter this a great deal in our career. Sometimes it's what drives people out of this career, and they just can't deal with it. I've seen a lot of dead people for every reason that you can think of. Every accidental reason, emotional, forceful, reason, all sorts of different things. So, and it's like I said, it never gets easy. It's, it shouldn't get easier per se. It should always affect you in some way. If it doesn't affect you in some way, then you probably want to talk to somebody. You want to, if you feel like, oh, yeah, whatever, what's for lunch? See you guys, then you probably want to, take a break and maybe, reevaluate, what's going on with you. Generally, these types of things should at least, either, play on your emotional side a little bit, and I'm not saying that you're going to go back to the ambulance or the fire truck and cry your eyes out and, or anything like that every time. But, if nothing else, you just have a conversation, in your mind and, that, this is wrong, this is bad, I hate that this happened, this is unfortunate, these types of things. And, and like I said, and you see experienced providers, that just deal with it, to your face. It may look like that, but when they go back and in their mind, they are, they're heartbroken that this has happened to this patient, and that they don't, they hate that they couldn't do something for them, that sort of thing. try to consider the psychological needs of the patient and his or her family. Like I said, this patient may be, on their deathbed. You may watch them die, right? And so that's never easy for us. Whenever they're in your care now and they die, that's always something where you're like, man, I really wish I could have saved them, right? But you start looking into it, and a lot of times they're just not viable. They're not a viable patient. Doesn't matter if they would have been laying in the ER when that happened. They may not have survived. So, but nonetheless, you do everything that's in your power with the time that you have available and the resources you have available, and you do the best job that you can with what you have, and that's all we can do. I've beat myself up over calls over the years, here and there, where I was directly in charge of everything going on, and patient care and extrication and all this other stuff. And, I'll beat myself up, but talking to peers, talking to the crews that we're working with, and, slowly realizing that, I did everything that I could with what I had, if, and that's one of the things too that may help drive training. Helps drive resource allocation. So getting new or better equipment, or, enhancements on training techniques or tactics or something like that, may help the next patient, so that doesn't happen for the next patient. Try not to give false hope. And, it's one of those things where sometimes people are holding onto your arm, looking you dead in the eye, going, am I going to live? Please don't let me die. And that's a very tough situation to be in, and like I said, you just have to let them know, we're going to do everything we can we're going to do everything we can to help you, just try to relax, be calm. Let us do whatever we can. And, you see this a good bit in vehicle accidents, where people are pinned or trapped or something like that, and they are, they're seriously injured, and they haven't bled out yet, or they they haven't developed a serious breathing problem yet, but they have some respiratory damage or something, and they're just hasn't progressed to that point yet. But they have what they call impending doom. They have this feeling that, hey, something bad is about to happen to me, and I can't control it. And so they'll start to plead with you, call my wife, call my husband, call my kids. I want to talk to my kid, whatever. So it's like I said, it's a fine line, and you really have to be cautious about how you handle that. But we try not to give that false hope and just go, oh yeah, man, yeah, don't worry about it, everything's gonna be fine. Oh yeah, you're good, man. Yeah, oh yeah. No, we're not going to do that. It just, especially again, other people being around and all that, and it's too risky to try to do that. And it's definitely, if they don't make it, and the family hears you say all that stuff, and, I thought you said it was no problem, you're going to be able to save them, this and that. I mean, it's just not worth it. So critical incident stress debriefing, again, this is part of that mental first aid that we mentioned. And again, we really need to be good practitioners of this. All right, if this is very foreign to you, if you don't know anything about this, if you're going to stay in emergency services, you need to be better at this. Okay, you need to seek out some more resources. You need to read some more. You need to watch some videos, and be better at this. All right, this is one way that we definitely can help each other, and we can help our patients. All right, with better knowledge of CISD. Like I said before, this extreme stress, these incredible scenarios that we find ourselves in, could cause us, to have depression, inability to sleep, nightmares, weight changes, increased alcohol consumption and drug abuse, suicide, lack of interest in food or sex, inability to get along with family and coworkers. And this is generally where you start to see that type of stuff manifest in people, and they may not realize it, but you're on the outside looking in, and you see these things. You see, Justin, man, he's normally, he's bubbly and talkative and playful and, picking on people and all this other stuff. And now he's reserved. He doesn't say much. He just does whatever he absolutely has to do, and that's it. Normally he's a really hard worker, and he's really proactive in what he's doing. And now he doesn't want to go eat lunch with us, and he always eats lunch with us. What's going on with him today? What's going on with him this week? Geez, man, he's been acting like that for like a month, right? We want to start raising an eyebrow, and it may be something where we have to go to that person directly first and go, "Hey, bud, what's going on with you, man?" Nothing, man. Don't worry about it. And they start to maybe blow you off. And sometimes, you may have to kind of, "Hey, bud, come over here and talk to me. Hey, something's different. Something has changed, and we can see it. There's several people that can see it, man. You need to, I really wish that you would talk to me about it, but I understand if you don't want to talk to me, but you need to talk to somebody about whatever's going on with you, man. Something has changed in you, and it's changed how you act on a normal basis." Right. And so when we see those changes happen, it's imperative that we, either get them some help or, offer that help to them. One of the best ways of doing stuff like this, and again, it's literally like just putting your thumb on the paper cut and holding it up above your heart and just kind of, and holding it there for a little bit until the bleeding stops. Right. Just that initial, very first thing that we can do to help control the bleeding. And that is these debriefings. And realistically, if you can kind of sneak that in on people, when you have an incident, like, so we have a 4-car wreck, we have 2 kids that died and somebody lost a leg and, serious, bodily damage, somebody's, had an abdominal evisceration, their abdomen was ripped open and just had some bad trauma injuries and, all this other sort of stuff, and distraught family members and everything else. And, after you have something like that, or an active shooter, or, school shooting, or, any number of things like that, bad burns, you bring people together, bring the ambulance together, when the ambulance gets done transporting people, "Hey, would you guys come by the fire station?" Or, "Hey, will you guys come by the sheriff's department?" And we just want to have a quick, little debriefing about everything, and just kind of see what we could have done better, or see if anybody has any issues or anything like that. And if you just get in a circle and just go around the room, some people, especially newer people, may not want to talk very much. But just hearing other people, maybe hearing an experienced person or something like that, share their thoughts, say, "Man, you know what, that kind of got to me. I was, the smell really almost made me throw up. And, I just, man, I've seen that too much. And I don't like seeing that. And, but I know I did everything in the, critical care algorithm for a paramedic that I absolutely could have done. I did everything. I did all the right drugs. The doctor said we did everything right. But unfortunately, she just had too much, brain trauma, and there was nothing that anybody could do." Right. So hearing the paramedic say something like that may let that new person, or that new, sheriff's deputy or police officer or something like that, and go, "Oh, thank God. I really thought that I screwed up when I first got on scene, and I didn't check on them. I didn't know what I was doing. I don't have any medical training, and I didn't know what I was doing. And man, I just knew that I was screwing up somehow, or whatever." Right. That may just take all the weight off of their shoulders that they screwed up, when, that veteran paramedic says, there was nothing that could have been done. Right. And just that alone, knowing that, hearing that from that person, may help that that patrol officer, deal with their critical incident stress. Right. And same thing, you provided some treatment for that patient, and you did several different things, and you're questioning yourself. You're not, you're an EMR. You're not a critical care paramedic. You don't know all the stuff that they know. So, you start questioning yourself about what you did, and did you do it right, and did you overstep your bounds, or whatever. Right. And so, even just talking to them, going, "Hey, do you guys see anything that I did wrong, or anything that I could do better, or whatever?" And, like I said, a lot of times, that's what that circle's for, is to get those things out there, and figure out, hey, what can we do better? And it may not be something that, cost the patient their life, that you could do better. It just, in general, oh yeah, well, if we had these, if we have the jump bag set up like this, we could probably get to this airway management kit a little faster. Or, if we had this type of rescue equipment in this configuration, we could probably get it up higher, or make it go farther into, the space or something, whatever. I mean, any number of things that can be hashed out during that time. And, some agencies will just do it amongst themselves. A lot of times when it's a really bad scenario, you'll end up with multiple agencies doing it. And we've done that in this area before, numerous times. But a lot of times, and just in general from the fire service perspective, we do this quite often, where even after just a non-traumatic event, we'll sit around with 5, 6, 7, whatever people that were on scene, and go, hey, what do you guys think about that? You see those fire conditions, what did you think about that? Did you see how that smoke was layering down? Yeah, well, this is what that means. Did everybody catch that? This is what we should have done when we saw that, or whatever. And hey, Johnny, you probably should have, put the truck a little bit closer this way. That way we could have more hose length or something, right? So we hash through those types of things for a effectiveness type standpoint, and just a way to work better type thing. So, and so it's very important that we do stuff like this to help alleviate some of that. And again, you may put everybody in that circle, and then you're working your way around, and you can't fake it. You can't not see it on somebody's face when they are acting differently. An hour later after this incident, and they're still just really reserved. They're not talking, and normally they're fun loving, carefree, ready to work and everything else. And here we are in this circle, and you're looking over there, and little Johnny is, has his head hanging down, just doesn't want to speak and everything else. And that may be one of those things where you go, hey, little Johnny, why don't you come over here and talk to me, man? Here's a cold water. I see you acting differently, man. Something bothered you on this call? What happened? And see, maybe in a smaller, and everybody doesn't want to talk in this big, this big group. So you may have to, that gives you the opportunity to see that, and pull them off to the side and talk, so. All right. That's a great spot. We're right about an hour. So we'll take a 10-minute break. We'll come back, and we'll start on chapter 13, environmental emergencies. All right, everybody, we'll go ahead and get started. So, environmental emergencies, like I said before, there's, heat, cold, all these different types of things, can work against us, unfortunately, and our patients. So it's important to kind of be aware how these things have that effect. More specifically, heat cramps, heat exhaustion, heat stroke. We'll go through each one of these and kind of talk about how they affect the body. Cold conditions as well, hypothermia, frostbite, frost nip, these types of things could be unintentional, where somebody just is having a good time. They don't realize that they're in the water for too long, and but when they get out of the water and they get a little wind on them, and and you can lower the core body temperature down and be hypothermic. So again, reviewing the dispatch information and just knowing, obviously, just as you come into work that day, you're out doing your normal daily thing. You realize, hey, it's 98 degrees out here, right? So if we have to do a vehicle electrification, or we have to go to a house fire, if we have to we have to go to a patient that is in some other bad situation, the heat is only going to make it worse. All right. And vice versa, it's 30 degrees outside and it's at night and it's windy. All right. And it's raining. That's going to make our operations, especially if we're dealing with stuff outside, it's going to make it, that much worse. Right. So again, trying to perform an initial impression of the patient. Again, we're trying to rule out any of those life threats right off the bat, and just them, being cold and shaking, is going to be even harder for us to try to get that information out of them. Or like we talked about before, maybe trying to get some of their vital signs may be difficult, and their breathing may be different because of the shivering, or that they're so cold they can't string together a sentence, right? Sorry, guys. Like I said, my internet's kind of acting up tonight, so it's kind of telling me it's going in and out of audio. Everybody hear me now?
Yeah.
Okay. So again, going forward here, determining the patient's responsiveness. Like I said, especially with heat casualties, they may be kind of lethargic and weak, and that's another one of those where we have to, make sure that it's not it's the heat issue and not some other issue, right? Of course, we want to introduce ourselves, kind of get them to focus on us, check the patient's ABCs, acknowledge the patient's chief complaint. Like I said, if they, say like an Alzheimer's patient or something of that nature walks off in the woods, while it's 30 degrees at night, and they trip over a tree limb, and they they hit their face on on the ground, and they're bleeding from their head or their face or something. That's probably something that we want to look at, making sure that their airway is okay and all that sort of stuff, before we really go into, whether or not they're hypothermic. But nonetheless, we can, try to help treat both of those. As a general rule, we can do multiple things at one time, but more specifically, we want to ensure that we're kind of working our way down to the most dangerous thing to that patient at that time. So like I said, as usual, we want to get that sample history as quick as we can. That way, in case our patient does pass out or get worse, we at least have, something to work with. And that secondary assessment is, really going to be focused on ensuring that the patient's vital signs are increasing, or they're getting better, and that we're getting them warmer or cooler or something like that. Hopefully that's generally how we want that to progress with heat and cold injuries, right? We want them to get warmer or we want them to get colder, whichever one is at play there. So heat cramps, generally one of those things that kind of comes a little bit later. Involuntary spasms of the muscles often occur after exercise, especially in hot weather, and legs, calves, that sort of thing is the most common area. Although sometimes you'll get it in the stomach, and so it says there abdominal cramps occur. It may appear that the patient's having an acute abdominal problem. So we talked about acute abdomen before, right? So this would be we want to talk about the events leading up to the cramps. Okay, so when we get to the E in sample, that's kind of how we start to define the difference between, well, why are you having these cramps? What were you doing before these cramps started? So the treatment, it's pretty general stuff here. Put your patient in a cool place, in the shade, something like that. Loosen constrictive clothing. Allow the patient down to a comfortable position. It says give patient water to drink. So if it's just heat cramps, have them sip on some water. We don't want to just chug water, but we want to give them cool water, not necessarily freezing cold water. Everybody thinks that freezing cold water is just going to be the best thing, but sometimes it can kind of be a little bit of a shock to the system if they're starting to get pretty hot. So, let them just sip, cool water. If they don't disappear, the cramps don't disappear, the patient is young or old, has a chronic medical condition, either or, we want to, probably let them get seen at the hospital or at least a clinic and make sure that they don't have any other underlying issue. Heat exhaustion, which is one that you kind of see more often, is when a person is exposed to temperatures greater than 80 degrees, usually in combination with high humidity. You can also occur as a result of vigorous exercise at lower temperatures. So for the firefighters in the room, it's one of the things where you may not realize it, but generally, if you go in your gear, even irregardless of if it's cool outside, if it's 60 degrees outside, and you have all that turnout gear on, you go into a working structure fire for your 15-20 minutes of your bottle time, and you go in and fight a fire. By the time you come out, you're probably going to be in some form of heat exhaustion. You would have to have hydrated very well throughout the day, be ready for this event, and be really well and be in pretty good shape, not to experience some mild form of heat exhaustion. So it's very important, for that reason to hydrate throughout the day and to ensure that you're minimalizing your exposure as much as you can. Obviously that's something that we can't really do much about it at the time, but definitely doing rehab in between, making sure you're drinking water, you're resting, getting out of your gear, that sort of stuff is very important. But again, for our patients, that's kind of the treatment for that, is getting them out of that area. Some of the signs and symptoms would be profuse sweating, lightheadedness. So again, remember when I said profuse sweating. Okay, so heat exhaustion, one of the main things they're going to see is sweating, right? If somebody's really hot, they sweat. Okay, so we got that for heat exhaustion. Just remember that. Dizziness, nausea, weak pulse, and low blood pressure. Okay. Some of the things that may make it worse or may make it more people more susceptible, or is very young or very old, pre-existing medical conditions. This includes having been a previous heat-related injury patient. So if you've had a heat exhaustion, heat stroke, something like that before, you are now more susceptible to that in the future. So again, high ambient temperatures, high humidity, like I said, just as a risk factor, that's an automatic. If it's high temp, high humidity, we can go ahead and say, hey, we're probably going to need to be looking for stuff like this if we get a patient that's outside, been outside, things of that nature, that's in some other type of critical incident. Now we're also looking for heat-related injuries. Again, move them to a cool place, cool, dry place. Monitor them for shock. Like I said, loosen their clothing, raise their feet up, and try to keep them warm. And when I say warm, if at this point, we're treating them for shock and they're starting to become cool, then we would want to try to keep them warm. But if nothing else, we want to keep them shaded, covered up, that sort of thing. Monitor the APCs and arrange for transport. Like I said, a lot of times they may be confused, and you start to get people that really start to get in a serious late stages of heat exhaustion, and you're going to see them becoming more and more confused, and we're working our way into heat stroke when that happens. So generally, when your a level of consciousness changes and from heat exhaustion, and you progresses into a level of consciousness change for the worse, then we are going into heat stroke. Okay, so this occurs when the body is subjected to more heat than it can handle, and the normal mechanisms for getting rid of the heat are overwhelmed. One of those being sweating. So when that mechanism is overwhelmed, we will stop sweating. Okay, so that's one of the big ones that we look for heat stroke, is that they are dry to the touch, or they're not producing more sweat. So the patient's body temperature rises until it reaches a level at which brain damage can occur. Okay, so that internal core body temperature is working its way through the other body systems and body parts, and making its way to the brain. The blood, right, that's traveling through the body is being heated. It's going to the brain, which is in turn heating the brain like a radiator, and the brain is sensitive, right? So it likes to be on an even keel. It doesn't like to be interrupted. And so whenever you get high body temperatures like that, 99, 100, 102, 103, especially in children, we get into 102, 103, it's not good. Okay, and we sustain that, we're going to have some type of brain damage. So again, flushed, dry skin that feels hot to the touch, semi-conscious or unconscious, like I said, a change in mental status, and an internal temperature as high as 104, and these are key signs that they're in heat stroke. Okay, so maintain the patient's ABCs. Again, their breathing is going to be weak, being unconscious, semi-conscious. They may be kind of rapid, light breathing, and we definitely want to remove them from the hot environment. We don't want to rapidly cool them down. In this case, it's better if we, take and try to get any kind of wet clothing off of them. Anything like that, underwear, things of that nature, put them in some dry type of, clothing or blankets. And again, we want to, it says soak the patient with water, but again, it's not freezing cold water. We're not trying to put them in an ice bath. Okay, that will cause that shock factor to increase. Okay, so cool water. We want to cover them with cool water. And if the patient's conscious and not nauseated, administer small amounts of cool water. Again, sips of water, not freezing cold water, just cool to the mouthfeel. And we definitely want to transport rapidly as soon as we can. So just talking about body temperatures, like I said, the differences here in heat exhaustion, heat stroke. Just again, going back over that, normal body temperature for heat exhaustion, heat stroke is going to be high body temperature above 100 to 104 ish. Heat exhaustion, we have sweating. Heat stroke, we typically don't. Heat exhaustion, again, cool and clammy skin, and kind of like I said, tacky, wet, type skin. And then for heat stroke, it's going to be hot and red skin. Heat exhaustion, like I said, a little dizziness, nausea, that sort of thing, especially in the late stage. But for heat stroke, definitely a level of consciousness change, and it's going to be semi-conscious or unconscious. All right, so those are the major differences there. So going into the cold injuries now, frostbite can result when exposed parts of the body are exposed to the cold environment. Okay, so they're out in the wind, they're out in the cold, and for an extended period of time, especially your digits like fingers, toes, that sort of thing, ears, face, stuff that's kind of out there in the elements a little bit more than say your knee or elbow or something like that. It's just much more resilient. However, with long-term exposure, the whole body can have frostbite, but really susceptible in the distal parts of your hands and feet and your ears and face, so your nose as well. So depending on the temperature, wind velocity, and frostbite, frostbite can occur quickly. So this is just a wind chill chart, just to kind of give you an idea of what the temperature is and what the wind is, and you kind of run that across there and meet in the middle, and you can kind of see what that might be. And then over the course of time, it'll give you a worse indication as the longer you're exposed to that wind chill. Again, people who are older age, medical conditions, exhaustion, things like that are going to make them more susceptible and ultimately better candidates for frostbite to occur. So superficial frostbite, or what I referred to as frost nip earlier, is affected body part becomes numb and then turns a bright red color. Many of you may have experienced frost nip before. It's you're out there working with your parents and fixing something late at night, and maybe a broken water pipe and you had a freeze or a frost or something, and you're out there at night trying to fix a broken water pipe and your hands are wet and all this other stuff, and you come inside, man, you hit the nice warm inside where the heater's at, and oh my goodness, my hands are stinging and hurting, and man, they're super red. Okay, that's essentially frost nip, and eventually the area loses its color and changes to a pale white. There may be a loss of feeling and sensation, temporarily. Warming the area must be done quickly and carefully. Do not warm the area by rubbing it. So, you want to maybe take a warm towel or even some, lukewarm water, just to help kind of raise that temperature up slowly and not so fast. So again, this frost nip continued, if you need to treat for shock, I mean, we're looking for those different vital sign changes. So if you do have some type of vital sign change, or a frost nip patient is also lethargic and unconscious and things like that, then yeah, we're going to start to treat for shock and try to make sure that they're getting that blood flow throughout the body. So deep frostbite, is considerably different here. The patient's skin will be white and waxy. So that waxy appearance is really the big kicker there. It does take a little bit for this to happen, unless you're in just extreme sub-zero conditions with a high wind chill factor for a decent amount of time. It may not take very long, but it will. It takes a minute for this to kind of take effect, and especially in this area. So, swelling, blisters, like you saw in the picture a couple slides ago, it can definitely be a pretty serious looking type damage to the skin. So again, with these blisters and the waxy appearance, cracking skin, potentially even a little bit of bleeding, surface bleeding. And again, it's one of those things where we got to make sure that we are protected also. So we can't, if it's an environmental issue where that person is outside in this environment, and we're having to treat them, probably best thing to do is get them into a warm environment before we really start doing a lot of definitive treatment. So that's going to be kind of almost step one in our treatment, is just to get them out of that environment. And that's for either one of them, heat or cold. Again, remove any jewelry, especially rings and things of that nature that might cause, especially because they're, again, like I said, their hands are going to swell or feet may swell, and we don't want them causing an issue. If we can, cover them with dry clothing or dressings in that affected area. And, don't break the blisters, don't pop them, try not to rub that area very much. Like we talked about earlier, we don't want to rub our hands together, rub our feet together. We don't want to apply like a heat pad or some other type of heating device or something like that. Again, it's going to be pretty painful. And some of it may be numb, but the other parts as it goes up, especially with immersion type frostbite, where it was submerged in water, you may have almost a line of feeling and then a line of not. And so above and below that line, you don't have feeling. And it's generally we don't want to agitate that area. So allow the patient to walk on an effective lower extremity. So if it's a foot or something like that, we don't want them to walk on it. We want to try to take their shoes off, loosen any, again, restrictive clothing around that frostbite area. Hypothermia. So just like we talked about hyperthermia a little while ago, this is where the person's body temperature drops to less than 95 degrees Fahrenheit. Again, 98.6 is kind of the textbook temperature. And so if it drops below 95 or 35 degrees Celsius, the body is not able to produce enough energy to keep the internal temperature at a satisfactory level. So especially if you are starved, you haven't eaten much, you don't have enough fluid on board, that sort of thing is going to make you even more susceptible to that. But also, if you have inadequate or wet clothing, and then individuals who are weakened by illness. Some of the signs and symptoms: feeling cold, shivering. That's the body's natural reaction to try to warm you up. It's a mechanical action that the body does to help generate energy. All right, it's friction, helps to create friction in the body, and try to build some heat. Decreased level of consciousness, sleepiness, lack of coordination, mental confusion, slowed reactions, unconsciousness. Sometimes a lot of times they'll start to work their way into the core. So, obviously everybody here has probably been cold before in their life, and you've done what? You brought your hands close to your chest. You may have been almost in the fetal position, and you were shivering. And so whenever you went to go extend your arm out, it may have even been painful at the joint a little bit, right? Had some stinging or almost felt like muscle strain, like you just been lifting weights in the gym. And so you almost have like a cramp in your arms. And, those are all, reactions to hypothermia. So, definitely, get that person out of that environment and try to get them, warmed up systematically. We don't want to, again, like I said, we're not going to throw them in a super hot shower. We're not going to, put, heating pads on them and all this other stuff. That's what they want. That's what we all want. But, it's, when it's a serious medical emergency like that, we want to do, a little bit more of a step process of rewarming. So again, some of the characteristics here, as you can see for hypothermia, similar to the hyperthermia, as that core temperature goes down, we'll start to see our conditions worsen. Okay, so as you can see there, signs and symptoms as it goes down. Some shivering, tapping your feet kind of thing, or shaking your arm or whatever. And then as you start going down, we have more loss of coordination, muscle stiffness, like I told you. Then we're going to go into the 80s. You're really going to be bad off, coma, again, unconsciousness, that sort of thing. And eventually death if we're below that point for any amount of time, a short amount of time, and you're gonna your body's just not going to be able to the blood's going to be not going to be able to flow through the body. Cardiorespiratory response, for that normal blood or that slightly lower temperature, just, constricted blood vessels, again, rapid breathing, the body's trying to compensate for that. And so it's constricted your blood vessels. And as you see there, it's more rapid breathing. And then as we progress lower, you're getting more into the slower respirations, slower pulse, and your body's almost starting to decompensate at that point. And then again, going into weak pulse, dysrhythmia, slow respirations, it's getting ready to go into cardiac arrest. Level of consciousness, again, withdrawn, like I said, just like, geez, man, I'm freaking cold, get me out of this, and so they're just kind of, like I said, huddled up, bound up like that. And so, whenever we start to go down, though, again, more confused, more lethargic, sleepy, can't even wake them up, that sort of thing. And then, of course, it's going to go into unresponsiveness. Again, bring them to a warm location. If they have wet clothing, we're going to remove that wet clothing. Get them some at least dry clothing. Place warm blankets over them and under the patient. Try to get them, under their armpits and, around their, around their genitals, around their neck, that sort of thing. And if the patient's conscious, give them warm fluids to drink. Again, not super hot, just, maybe a warm cup of coffee or warm water or something like that. If you don't have access to a building, move the patient to a heated vehicle. Anything we can do, try to get them out of the wind, or, something where we can provide some type of warmth for them. So especially if we're having a long transport to the ambulance. So if they're out, especially something we deal with lost patients, people who are, either, lost hunters or, people who have dementia or things of that nature, small children, who just wander off. And so we may have a long transport back to some area that we can actually treat them at. And so, be prepared to take in blankets and some type of warming device or something that we can, keep them warm while we're transporting them out of there, whether it's, on a stretcher or, excuse me, some type of litter, or, even if they're walking out, we can wrap them up with something and keep them warm. So cardiac arrest and hypothermia, if the patient's body temperature falls to less than 83, the heart may stop and you will need to begin CPR. That's kind of what we saw in that chart. Always start CPR and use an automated external defibrillator on hypothermia patients, even if you believe they have been dead for several hours. So again, a severe hypothermia patient, especially like in a submerged type environment and stuff like that, it's, we want to give the body every opportunity to kind of get warm first, or get warmed up, so we're going to do that CPR, do the AED, try to keep them warm, get them warmed back up. And, maybe it could have preserved the body to some degree that is, that'll work. And that's in there because it's happened. There have been people who were found dead, no pulse, no breathing, and had been there for a while. And generally, if it would be any other patient, they would absolutely be dead. No question. They got them back warm, in a warm area, got them back to I think almost like a morgue or a mortuary. And they ended up coming back to life. So as crazy as that sounds, just with that extreme amount of cold, it almost preserves, the body in a kind of a modified state there. And once it's rewarmed, it almost kind of starts back. So, not always the case, not the be all to end all, but definitely an opportunity that we want to give the patient. So speaking about submersion, drowning and submersion is, you know, pretty common. We see that a lot. We have a lot of water around us, right? So we see that quite a bit. I know the coast has had multiple drownings just within the last few weeks. They've had multiple bodies found and, you know, multiple people found in the water or had drowning incidents in the water this summer. You know, from Florida to Louisiana, there have been multiple coastal drownings, you know, around beaches and river fronts and stuff like that. So again, big thing, especially for children, 1 to 14. It's just, you know, for different reasons, but nonetheless, it's staggering numbers and it's just, you know, unfortunate events. So, you know, drowning is defined as the suffocation because of submersion in water or in other fluids. So essentially fluids fill up the lungs. Lungs can't breathe, can't move air, and they die. So submersion injuries result from being beneath the surface of the water or another liquid. So again, it doesn't have to be a deep into the pool or a lake or river. It could be a bathtub. Plenty of children have died in bathtubs that were 2 inches of water, and so it's absolutely possible, and that's why one of the reasons why we really need to keep an eye on children, especially small children, when they're in the bathtub or around any body of water. So streams, lakes, swimming pools, hot tubs, any number of things. Again, we've had adults who get, you know, have drink too much or recreational drugs or, you know, prescription medication or something, and they're just trying to relax. And man, this feels really good on my back. Let me take some medicine. Let me take some of my prescription medicine and get really even more relaxed and almost, you know, get sleepy. And then they, you know, they're semi-conscious anyway, and they pass out in the hot tub and end up drowning. Again, bathtubs and toilets, mop buckets, you know, any of these little things where we just, you know, children, small children especially, would be inquisitive about what it is, and it looks like, oh, it's water. It's, you know, I like to play in water, and so they end up, you know, falling headfirst into a bucket, you know, and that sort of thing, while you go and wring out the mop or, you know, something like that, or you know, you go and wring out the sponge from washing the car, you know, and they're out there helping. So little things like that can be a big deal. So again, usually the initial stage is panic. You know, even if you can swim, you get to a point to where you realize that you're not making any progress, and you realize that lack of progress is also making you become fatigued. And so whether it's you know, whether you get injured or you're cold and tangled, something like that, it's generally going to cause you to panic, and you know, you kind of experience a loss of orientation, maybe which direction you need to be swimming in. So especially with something where there's like waves and current and stuff like that, as you turned around, you could swallow water, and your swallowing water may not be the best tasting water. It could be salt water, could be, you know, something like that. So you end up maybe vomiting because you drank too much water. And so that's causing you to be, you know, fatigued as well. And usually that panic produces an inefficient breathing pattern. So you're again, same thing if you're drinking water and you're not able to control your breathing. So like I said, coughing, vomiting, difficulty breathing, respiratory arrest, cardiac arrest, broken bones, spinal injuries, hypothermia, you know, any number of these things could result in submersion injury or drowning. You know, like I said, you slipped, fell, hit your head or whatever, and now you can't think straight and you can't swim for yourself. You can't keep yourself afloat. All right. So again, hypothermia, like we mentioned before, you get submerged. Usually, when the water temperature is low, it doesn't have to be very low either. You know, some people think, oh well, you know, if it's like above, you know, this temperature or that temperature, or, oh, it's hot outside, man. You know, it's not a big deal. And they don't realize that the water temperature could be vastly different than the air temperature outside, and just being in there during, for a longer period of time could cause you to become hypothermic, and then therefore, like some of the other signs and symptoms that we talked about in hypothermia, may cause you to again not be able to function well. Your arms won't have the strength, legs won't have the strength and mobility that they once did, and so you won't be able to swim your way out of it. Treating submersion injuries, or basically accessing the scene, is important that you are very careful, especially around moving water. You really want to make sure that you are that you know what you're doing, and that you have the right capability to get that patient out. It's very common for rescuers who are inexperienced or untrained to end up in the water as well. So if you are not dressed for the occasion, you don't have flotation. For those firefighters in the room, I will tell you this: it's one of the cardinal sins of swiftwater, and that is for the fire service to approach the water's edge with turnout gear on. It's a big, we all think, oh man, it's freezing cold out here, I'm gonna put my turnout gear on and we'll just throw them a rope, or we'll just do this, we'll just do that. We're not getting in the water. And then eventually that the need to help someone overtakes that understanding, and generally you'll end up doing whatever you think you need to do, including getting in the water in your turnout gear and to help that person. So, or you'll get drug in by, the current, or somebody throwing a rope to somebody and you're holding on to it, and you get pulled in the water inadvertently, and now you're in your turnout gear. You never trained to be in the water in your turnout gear, and you will almost certainly not survive. All right. It's unless you have that knowledge, you're going to panic, and your boots are going to fill it with water. And again, if you haven't trained for that, you're going to be in a world of hurt. Okay, real fast. It's not going to take long, and you're going to be completely overweight and have no buoyancy, and you're going to sink. Okay, so very important not to get around the water's edge unless you have some type of flotation on, and you have some way to access that victim. Sometimes we may have to wait for some type of specialized, personnel to go get the patient for us. In that time, it's good to start that primary assessment from a distance, right? If we can call out to them, if we can talk to people who may have already been interacting with them, and kind of give us an idea of what they look like, we may be able to shine a light on them and see them sitting on top of their car in a flooded street, and see them shivering, see them with their arms closed in tight, them shivering, they're curled up in the fetal position, have their knees high to their chest, and they're trying to keep that warmth all close to their body. They're soaking wet. All these things we're already answering questions in our primary assessment. Okay, so again, if we're able to call out to them, see what their level of consciousness is, keep them engaged, keep them a positive mental attitude, a lot of these things will help them survive this, and help them survive the hypothermia side of this incident. So again, once we get them out, we're checking them for all these different issues, making sure that we have good ABCs. Of course, if they're submerged for any length of time, we want to again begin CPR, whether it's hot or cold, and ensure that we we give them a fighting chance. Hopefully, we can try to get some of that fluid out of their lungs, and have a good airway and airflow back and forth. If they are breathing adequately, we can give some oxygen, help calm them down. Doesn't hurt. Dry the patient off. Again, whether hot or cold, try to give them something to dry off, or dry clothes, and then cover the patient with towels or blankets. Again, cold water drowning, like we're just kind of mentioning, it's imperative that we begin CPR on a drowning victim as long as the patient does not exhibit the definitive signs of death. We mentioned those before. Dependent lividity, where the blood is sunk down. If they're in rigor mortis, where they are it's not just the cold, it's their joint just will not move. They're so stiff. Obvious deformity, to the head, that sort of thing. Those are those signs, we can't ignore. But in general, if they were just, drown, if they had just drowned recently, then then we're going to try and do that CPR as best we can. So when a person is submerged in cold water, the mammalian diving reflex may be activated, and essentially the protective reflex slows the heart rate and metabolic rate and decreases the body's demand for oxygen. And so we want to try to, again, get to that patient as fast as we can so that we can help to regulate that. Again, when you encounter a person who has been submerged in cold water, start CPR and continue it until the person has been delivered to a medical facility. It's just one of those things. It's one of those freak things that's happened before. And so, like I told you earlier, we want to give them every opportunity to survive. Lightning injuries, again, just one of those things. It's very rare, but it does happen. And the biggest thing is that cardiac arrest or cardiac irregularity may occur. Of course, that as well as burns. So you could have, entry and exit wound burns on the body, and it's usually pretty painful. So the whole thing is pretty painful. If you've ever been tased, for those of you who've been tased or shocked by an outlet or something like that, or electrical wire, it's painful. Okay, so just remember that. Oxygen administration, defibrillation may be one of the key things here. Again, it may have essentially stopped the heart because it interrupted that electrical flow to around the heart, and so we may need to defibrillate them and restart the heart that way. But CPR may be needed for some patients, and patients must be transported to a medical facility right away. But again, we're also looking for these burns. Again, they'll probably have a path, a travel path where that electricity goes throughout the body, and so there's going to be generally an entrance type burn or wound, and then there'll be an exit, so someplace where it comes out at, and so those could have some type of burning or bleeding or something like that to them as well. So bites and stings, sometimes classified as environmental injuries. We kind of talked a little bit about it during poisoning, the other night, but it's just one of those things that we may have to deal with from the environment. It may be a product of the environment that we're in. So especially, it doesn't just have to be in the woods or out in nature. It could be close to a house or anything like that we're dealing with. So it could be in the water. A lot of our rivers and creeks and things like that around here have bundles of ants, spiders, snakes, all sorts of stuff. So, again, it's a lot of things that are out there in nature, really can have a serious effect on our patients, on us as providers, how well we can provide that care. And it really needs to be, something that is at the forefront of your mind as you're responding, and as you prepare, throughout the day for if you're on a shift, or, if you have the potential, if you're going to be responding to stuff that day, think about that. Hey, what's the temperature going to be like today? What's the wind going to be like today? Since it started getting cooler, I don't know what the temperature is right now outside, maybe in the 50s or 60s or something like that, I assume. But, if you add a little bit of breeze to that and we're in the open, you can get really cold in, 60-degree weather with a good little wind chill. You can go back and look at that wind chill chart and see what that might be. And it may be pretty significant to your patient. So even though, you're wearing a t-shirt responding, your patient may have been out there for 4 hours in 55-degree weather with a high wind chill, and so they may be close to being hypothermic, and, something you need to think about. So, but anyway, that's all we have for tonight. the course code for tonight, again, for both of these classes is going to be R0009, R0009, and that's for chapters 12 and 13. So again, I know most of you are a couple, at least a couple of your quizzes behind. So again, I say it every night. Let's go get in there. Get your studying done for those chapters and work your way through those for those quizzes. Okay, being a couple behind here and there for a little while is fine, but we don't want to keep doing that the whole time. So, anybody have any questions on anything we covered tonight, or any general business you need to bring up? All right. Well, that's it. I appreciate it. Again, if you guys have any issues or questions or whatever, feel free to reach out, and we'll do our best to help you. You have a good night.